Okay, hi everyone, welcome back. Everyone has had their biological break. Okay, my name is Dr. Fong. I'm an intensivist in Hospital Queen Elizabeth. The topic for today is managing COVID-19 in the ICU, and I've been managing COVID-19 patients in our ICU for the past 2 years now, and have been handling mainly COVID patients. So much so that we've seen the evolving nature of COVID, the different changes that we've gone through throughout the past 2 years. So I hope to share a bit today about my experience and also to review some of the new updates that we have. So this is the outline of my talk. There's a bit of epidemiology, some of the phases and clinical features of COVID-19, and then our management in the ICU and the review of current interventions. So from 2020 to this year, we had about 1,500 cases coming into our ICU and HW, and we have had about 200 over deaths. That's about 17% mortality overall. But as I will show you, this is our graph over the past almost 2 years. So you can see the spikes during the COVID surges. So this one, the first wave, and then the second wave, and then this is finally at the current time. So the red color is deaths due to COVID. And you can see this spike in deaths. This was during the Delta wave, which we saw, we had a very majority unvaccinated population, and the Delta wave just hit us very badly. Yeah, lots of patients died here now. Then the green one is actually deaths not due to COVID. Yeah, it's a flat line down here. So we always had a few patients coming in who died, but not due to COVID. If you were to look at the confirmed cases in Sabah, you can see the 3 spikes here. So this one is below 1,000 cases. And then the second spike was 3,000 cases. And then last spike, this current spike was about 5,000 per day. And if you were to overlap it according to, to these graphs that I've shown you, you can see that during the first wave, even though the cases weren't that much in Sabah, but there was many ICU admissions. But somehow the deaths were not that high. Yeah, mortality was around 10%, 20%. But during the Delta wave, it went up to 3,000 cases. The spike in cases was very high. We had up to even 60 patients in our anesthesiology department managed ICU at one point. And the deaths were up to even 40-something%, almost 50% at one of the months in September. But the latest wave, this Omicron wave, even though the cases went up to 5,000, but you can see that the rise in ICU cases is not that much. And thankfully, the death is very low. In fact, for March, if you look at this graph, green color is death not due to COVID. So I'm very happy to say that in March, so far we have not had any COVID deaths. Yeah, patient has been coming in for all other reasons except for COVID ARDS. We only had, I think, 1 or 2 COVID ARDS cases in the past 1 month, I think. So they're coming for MVA, strokes, heart attacks, dog bite, all sorts of things, but hardly any COVID ARDS. Yeah. So when we came up with the idea of giving this talk, of course, we had lots of COVID ARDS, and I thought, look, we need to focus on COVID ARDS. But as time has changed, so I'm going to focus, I'm going to tell you guys a bit about these different phases of COVID and how we can better target our therapy. So you look at COVID infections, from the initial week, from first infection and incubation period, there's actually a rise in the viral count, okay? But by the end of the first week, around day 10, the viral count has already come down, yeah. So of course, the PCR will still be positive at the time, but then this is when your body starts to react and you start developing antibodies, IgG, IgM antibodies, and you can detect antibodies. We used to have antibody kits, but it wasn't very reflective of current infection, so we're not using it to detect current COVID. But you can use it to detect whether the patient has formed any antibodies against COVID. So by the time about week 3 and so forth, PCR likely can turn negative or very high CT values. By here also usually your RTKs will be negative, right? So if you look at this chart by an article by Myrick, he showed that viral replication is within the first 10 days. After that, we are facing more of viral debris, yeah, and the subsequent problems that we face are usually due to immune dysregulation. Yeah. So similarly in this chart, you can see that this is a more simplified chart. The early infection is more of the viremic phase, and it goes into this pulmonary phase where there's a direct direct lung injury due to the virus, right? And it also coincides with the rise of the host response. So as the host response increases, so you can see the rise in CRP, you can see all the inflammatory markers start to rise, and patients can go into the third stage, which is the hyperinflammation stage, where they can develop cytokine storms, lung dysfunction due to the host response, actually. Not only lung dysfunction, but lots of other organs as well. So we have known over the past few years that we have CNS alterations, some patients coming with seizures, neuropsychiatric changes, even peripheral nervous system like GBS, Guillain-Barré syndrome. You can get cardiac injury, myocarditis, pericarditis, heart block. You get blood alterations, thrombocytopenia, lymphocyte count drops. You have hyperinflammation, CRP, procalcitonin, ferritin, interleukin-6 is raised. Hypercoagulability, yeah, D-dimer, fibrinogen raised. Electrolyte imbalances. We've had so many cases of hyponatremia, hyperkalemia, hypokalemia. Some of them come in with such severe electrolyte imbalances that they come in unconscious. Immune system alterations, pulmonary disease, I've already mentioned, liver dysfunction. Many of them come in with raised ALT and ASTs later on in the disease. Kidney dysfunction is quite common. You can also get rhabdomyolysis. So I would like to introduce all of you to this term called immunothrombosis. So when a patient has a COVID infection, the SARS-CoV viruses actually gain entry into the cells via the ACE2 receptors. When that happens, actually, it triggers a few responses. On one hand, you develop, if the SARS-CoV viruses enters into the alveoli, enters into the endothelial cells, it causes injury and it exposes the tissue factors. And all the other coagulation cascade starts to develop, and you can get fibrin deposits and get intravascular clots. Besides that, the host response starts to get activated, and all these cytokines, chemokines will also trigger the coagulation cascade and trigger further thrombosis. So, which is why in COVID-19, you can see a rise in venous thromboembolic diseases. Some studies show 20%, some goes up to 30-something% in COVID ICU patients, such as the DVT, pulmonary embolism, right? So there's also increased risk of stroke. ACS, MI seems to be a very, can be a presenting feature of COVID. Many of our patients come in with MI and they're noted to be COVID positive. Mesenteric peripheral ischemia, we had a few patients who come in with intra-abdominal sepsis with, for example, the cecum with unhealthy and then develop perforations. It could be, and patient COVID positive, it could be part of this thrombotic complications as well. Microvascular changes, purpuric skin rash, COVID toes, fibrin deposition in the lungs of these autopsy patients that they do autopsy on. So there are some strategies that you need to use to treat thrombosis. Yeah, we'll go through them later, but roughly these are the ones. So stop the inflammation, we need to anticoagulate them, and some suggest even thrombolytic agents. Also recently, there's been a rise in multi-system inflammatory syndrome in children. And unfortunately, it's not only limited to children. So I think the current CDC guidelines also recognize multi-system inflammatory syndrome in adults. Although it's not that common, but this is a suggested presenting symptom that should trigger you to think that patient may be having some sort of multi-system inflammatory syndrome post-COVID or during COVID. So ongoing fever is a must, with stomach pain, bloodshot eyes, diarrhea, dizziness, skin rash, vomiting. So when I think back, some of our patients did present with these kind of symptoms, yeah, especially diarrhea, stomach pain, and vomiting. It's quite, they come in, but usually they come in with severe, hyponatremia or DKA already, and I wonder whether it is due to multi-system inflammatory syndrome as well, because they come in with such high inflammatory markers. So this is the case definition, which I'm not going to go through. But the case series that the CDC presented in their website showed patients coming with cardiogenic vasoplegic shock, hyperinflammation. They needed steroids, they needed therapeutic anticoagulation. Some of them coming with stroke, hyperinflammation, COVID positive. Some coming with cardiac dysfunction, abdominal symptoms, rash. We have had patients with this constellation of symptoms, and the role of hyperinflammation caused by COVID is, I think, most likely explains some of these cases. The thing with these cases is they do not have such severe respiratory symptoms. So, some patients come in with no ARDS, but they have all these other issues from immunothrombosis and hyperinflammation. Sometimes, we overlook the fact that these patients need steroids, even though, they do not have COVID ARDS. And other very severe complication of COVID ARDS is organizing pneumonia. We have had many of these cases in the past 2 years. Recently, due to the vaccination program, thank God, the rate of organizing pneumonia in COVID-19 is definitely a lot lower. These patients, although they recover from the initial COVID, they continue to have severe hypoxia, requiring prolonged oxygen supplementation, even up to discharge. They go home on long-term oxygen therapy. So now we hand over to our respiratory physicians to continue their care. Thankfully, according to respiratory physician, they do recover. These patients, they do recover within about 3 months. Yeah, so it takes time, right? So these are some of the CT scan of a patient with organizing pneumonia, some patchy subpleural consolidations. You can see some ground glass changes, reticular opacities here, and these are some other ground glass changes. Yeah, like this, like grayish area. This is a picture of one of our patients, 46-year-old male, diabetes, day 8 of illness. He's on NIV at the time. Saturation was 92%. And his lungs, you see the gray areas, those grayish areas are actually the abnormal lung. The good lungs are the dark ones. So you can see just patches of good lungs here and there. So 90% of the lung is, is affected. And I discussed this with our respiratory physician, and she says this is organizing pneumonia, affecting majority part of the patient's lungs. Yeah. So he made it through, but it took him very long to recover. So for these kind of patients, you need higher dose steroids. Yeah, you pulse those steroids and a prolonged tapering of the steroids. So if you were to look at these phases of COVID and where we can target our therapy, of course, pre-COVID, you would preferably want everyone to be vaccinated. This definitely reduces the risk of COVID ARDS. Definitely. The rate of COVID ARDS is so much lower now. In the initial stage of COVID infection, you would want to target the viral response. So antivirals, I think the newer drugs, molnupiravir is out. So it has shown to reduce the risk of developing severe COVID in outpatient and also before patient gets worse. So I think this antiviral therapy, like even remdesivir, you should give it early to reduce the viral load so that the patients don't go into the pulmonary phase and inflammatory phase. Monoclonal antibodies, later I discuss it, for certain cases to reduce the viral load, but it's not widely available. Antivirals, steroids, immunomodulators, somewhere in the middle of the pulmonary phase, all the way to the hyperinflammatory phase. You want to modulate the host response to avoid cytokine storm, to avoid host response-induced lung injury, for example. Anticoagulation, blood purification, anticoagulation definitely, within the hyperinflammatory phase. Some other therapies like blood purification, antiplatelets maybe, I'll talk about it later, and thrombolysis even, I don't have any slide on this, but some studies are ongoing to examine the use of RTPA to treat COVID-19 ARDS. And actually, I'm involved in the study, but it's not easy to find patients nowadays thanks to the vaccination program, which is great. So after the host response, and then as you go further down the line in COVID infection, there's a risk of developing multi-system inflammatory syndromes, organizing pneumonia, post-COVID syndromes, and these typically get treated with immunomodulation, like steroids and so forth. So you'll get patients who they refer to you with chest imaging features of COVID. And just to recap some of our changes, I think we have seen so many in the past 2 years, right? All of us are getting familiar with it. So number one is normal chest X-ray does not exclude COVID-19. Ground glass opacification, 68% of them. Bilateral involvement in majority of them. Usually it's periphery of the lungs near the chest wall. And they have these patchy kind of like streaks, linear opacities, horizontal linear opacities. For example, this, So for the year man or nasal prong, there's this linear line, linear kind of opacities. You can see a grayish, more on peripheries of the lungs. This man is this lady as well, 29-year-old. She's on room air. Stress test is positive, but doesn't need any extra supplementation at the moment. And then this one is this kind of lines, and opacities. So then you can see the worsening of the COVID changes. This is an obese patient. And this is a very severe patient. I think this one, she already has probably some underlying chronic lung disease. So when coupled with COVID-19, you can see the increased ground glass appearance all over the lungs. Another patient. And this is a picture very similar to the CT scan that I showed you guys earlier. Okay, so just this man has ventimass 40%. It looks very bad, right? But somehow the changes in the lungs in the imaging does not always reflect the amount of oxygen that the patient needs in COVID. So I'm just going to go through some of the things that I do in the ICU, and later we review the evidence a bit. So number one is ICU admission. For Hospital Queen, we admit most of the patients who require high flow mask and above. During a surge, I think initially we used to admit high flow mask and above. Nowadays, I think the medical ward is much more better equipped and more skilled at handling COVID patients. So they're handling most of the patients on venti masks, even high flow masks. There's even 1 or 2 cases on high flow nasal cannula in the ward nowadays. If patient is intubated, definitely we'll bring it to the ICU. High flow nasal cannula, NIV, definitely in ICU. Some patients that we think are high risk for deterioration, patient in distress, patient with shock organ failures, we'll bring into the ICU. It really depends on the triaging of this patient, really depends on the bed availability. During the surge, we had a lot of cases that were managed in the ETD. Some patients lasted for 5 days, 6 days in ETD, a week even. Unfortunately, we already had no beds. We had 60 full ICU beds, 60 beds totally full, and we just could not bring any patient in at that point of time. We really had to pick and choose the best prognosis patients. Those were very, very difficult times for all of us at that time. So some poor prognosis cases, we have to manage it outside the ICU until we get a bed available during surge. I hope we don't get another surge anymore after this. Maybe next, hopefully there's no more next one, Delta Cron or whatever. So for oxygen support, if there's any signs of respiratory distress, I think these patients need oxygen support. You must be very aware of silent hypoxics. A lot of patients come in with saturation less than 90, but they're perfectly fine. They'll tell you they're fine. They can talk to you. They can makan minum, no problem. But you check saturation, it's less than 90. So if you look at the patient and there's increased work of breathing, when they talk to you, you can see they take deep breaths and then they talk, and then they run out of breath halfway through sometimes. The CO2 might be low due to hyperventilation. Respiratory rate is typically high. They can speak in short phrases or words, but they don't look like they're in distress. So it's silent, the hypoxia. So this is the range of oxygen support that you can give. In my setting, in our setting in Hospital Queen, we try to avoid intubating the patient. We start off with high flow nasal cannula, maybe NIV, but as far as possible, we try not to intubate the patient. We aim saturation above 92, PaO2 more than 60. As long as the patient is not in distress, she can eat and drink, she can call on the phone, She can message her, family, call them. She can do self-proning. I feel as long as we maintain the patient's comfort without intubating them, I think that gives them a better chance of survival. I'm not going to, I saw some articles discussing regarding the use of HFNC and NIV, whether that prevents the need for intubation. Some studies do show that, but they're not peer-reviewed, and the evidence is not very strong. So I'm not going to share them, but from our experience, I think a quarter of our patients are intubated, and those patients are those that are very, very ill. Unfortunately, mortality for those who were intubated in our ICU is almost 50%. Yeah. So those who are not intubated, even hypernasal cannula, we were giving them 100% oxygen sometimes, flow of 60 for days. NIV sometimes 100% oxygen on NIV for a month. And they got through without being intubated. Yeah, so they remain GCS full. They can talk to the family. Sometimes we remove the mask, let them drink. Yeah. So I try not to intubate them. Yeah. So last time, I think when the start of COVID, early intubation was the preferred choice in many centers. But I think as we go down further down, we realize that intubating COVID patients, the amount of workload increase for the nurses, the amount of ventilators that you need to do early intubation for all these patients is just not feasible in our setting. So this is self-proning. Many of our patients do a lot better on self-proning. Although the recent, I think Cochrane and some guidelines, they mentioned that there's no strong evidence to suggest self-proning actually improves mortality. But from our personal experience, self-proning definitely increases the oxygenation. And we have had some patients who can prone themselves for 23 hours a day. They only supine to makan, minum, and then they prone back. They're very compliant. And some of these patients, they do so much better and they improve tremendously on self-proning. So the longer, the better, if they can prone. Yeah. Indication of intubation, as usual, if you fail a HFNC, NIV, patient is still dyspneic, very severely tachypneic, increased work of breathing, or they can't protect the airway, then definitely you have to intubate. I use a lung protective strategy as well for our COVID patients. Small tidal volumes, permissive hypercapnia, permissive hypoxemia, almost, yeah. Saturation 98 and above. Driving pressures less than 15, optimal PEEP. We do proning for these patients, and also neuromuscular blockade. Proning definitely helps. The effects of proning actually last longer than the proning duration. You prone the patient for 16 hours, the effects of the improvement can be seen even after 24 hours. So proning definitely helps. Paralysis, many of these patients require prolonged paralysis. Unfortunately, to mobilize them early, and really can't do it. Every time we wean off the paralysis, they become delirious. It could be part of the neuropsychiatric response of COVID, because we seem to see a rise in the use of sedations in COVID patients. But previously, we used to use like 2 to 3 milligrams of midazolam. In COVID patients, we use up to 10 milligrams, 15 milligrams of midazolam infusion, morphine up to 15 milligrams, fentanyl, 100 mics, very, very high doses of sedation just to keep them comfortable. And I'm wondering whether COVID it plays a role in causing this so-called resistance against sedation. We also considered using partial paralysis, and we successfully did on a few patients using, partially paralyze them. They can still breathe on their own, but at smaller tidal volumes to ensure lung protective ventilation. And some of them did quite well on partial paralysis. I haven't managed to find strong evidence for this, but it's a consideration. Yeah. So if you have a patient with COVID and they develop worsening lung function, the usual suspects, number one is, of course, worsening COVID, maybe organizing pneumonia. And these kind of patients, if there's unlikely to be any bacterial infections, sometimes we increase the dose of steroids. Sometimes we consider, most often we consider giving tocilizumab or baricitinib. Another possibility is pulmonary embolism. Yeah, the rate of VTEs in COVID patients are very high. If the D-dimer is raised, do a CTPA. In the meantime, if there are no contraindications, I would start an empirical therapeutic anticoagulation. So therapeutic dose of Claxane, for example, until we can get the CTPA and confirm yes or no. New onset of HAP or VAP is another possibility. So in these kind of patients, procalcitonin might be raised. Patient get a new onset of fever, maybe. The X-ray changes show more of lobar pneumonia rather than those ground glass, diffuse kind of picture. Then more likely to be bacterial. Then you want to start empirical antibiotics to treat for HAP or VAP. In these kind of cases, I tend to cut down the dose of steroids earlier and avoid high doses, and I will withhold the baricitinib and avoid tocilizumab in these cases. Other suspects, pneumothorax, quite common in COVID patients. Some patients, even on just high-flow nasal cannula, they develop pneumothorax. They develop subcut emphysema. Secretions, lung collapse, cardiogenic pulmonary edema, fluid overload, pleural effusion are the other suspects. Many of our intubated patients require tracheostomy if they survive, and those who had tracheostomy do quite well. Yeah, they do quite well. I think they already went past the most difficult parts of their disease, and once they get tracheostomy, they continue to improve. So what medications do I use in our ICU? Number one, top of the list is methylprednisolone. Most of our patients with moderate to severe COVID-ARDS get methylprednisolone. Now with the changing landscape, I hardly have to use methylprednisolone, and because hardly have any COVID-ARDS nowadays. So most of them can just get through with dexamethasone, or if they don't even need oxygen support, PF ratio is normal, then you don't even need to give any steroids for the ARDS. If it's not there, you don't have to give. Intermediate dose Claxane for most of my patients. We try using lower dose of Claxane, seems to be higher. I seem to see more VTEs, although evidence, later I show you. Treatment dose Claxane only for those with suspect PE. Yeah. Tocilizumab, baricitinib, yes, definitely for those with raised inflammatory markers and also those with severe ARDS. Empirical antibiotics, yes, when they come in, usually to cover for melioidosis and so forth. Liberal fluid strategy for the first 2 days, and then ensure adequate nutrition. And I use some dihydrocodeine for symptomatic relief of cough. So this is how I decide what to give my patients. Is the PF ratio less than 200, that means severe or moderate ARDS, then I will use methylprednisolone. Usually by the time they come in, the ETD or medical team would have already given a loading dose. Patient would already be on 1 milligram per kilo BD, and usually I use ideal body weight. So I will just titrate down a little bit to ideal body weight. IV dexamethasone, if it's not so bad, can give 8 milligram TDS or BD or OD. But typically nowadays, we just Dexa 6 OD is adequate for most patients nowadays. Post-vaccination, the rate of ARDS is much lower. If you're using tocilizumab, if I'm using tocilizumab, I would cut down the steroid dose if I can. Yeah. So there's some evidence for dexamethasone. I think we've already probably read this before. Dexamethasone usage was shown to improve the survival of hospitalized patients with COVID-19 for patients who require oxygen support, and those who were mechanical ventilators. So you can see that with mechanical ventilation, dexamethasone reduced the mortality, compared to usual care without. And those who with oxygen reduce mortality. But if the patient does not need oxygen, then using dexamethasone actually increases mortality. So if you have a patient with COVID-19, don't automatically start Dexa. Yeah, look at the patient. Look, PF ratio is normal, patient is fine, no ARDS, then there's no need to give any steroids. For I didn't share more. Actually, there's some other studies, comparing like methylprednisolone versus Dexa, but they're all many small studies. Evidence is not very strong, but it seems to be a class effect. Dexamethasone, hydrocot, methylprednisolone, prednisolone. I feel they can all be used to modulate the immune response in COVID-19. Yeah, I think there were some studies that show methylpred is better. Some show no difference. So you just have to wait for more information on that. Anticoagulation, I tend to use 1 milligram per kilo per day if patient has no renal failure, or I just use acyclovir. I will initiate mechanical thromboprophylaxis, the intermittent cuff pumps, DVT stockings. If the patient has high risk of bleeding, no evidence of hypercoagulability, let's say the dilemma is normal, fibrinogen normal, actually standard dose prophylaxis has been shown to be adequate. If you are more worried about VTEs, you start low and taper up. Yeah, because we have had quite a few cases of severe upper GI bleed, retroperitoneal bleed, bleeding from the lines that we insert. So instead of therapeutic dose, I've gone down to intermediate dose, which I seem to find the best for my setting. But in terms of studies, there's shown that there's no difference in preventing VTEs, comparing therapeutic versus prophylactic dose, in COVID patients. Furthermore, if you were to give therapeutic dose, there's more bleeding. In terms of intermediate dose, there's also no difference in terms of thromboembolic events. So using prophylactic dose in your setting is good enough. In certain cases where you see the D dimers are high, maybe, you might want to consider going intermediate dose. For me, if the D dimers are high, I will go for enoxaparin 1 milligram per kilo per day. But keep in mind, in this study, so they show the higher risk of thrombocytopenia in the intermediate group, and a slightly increased risk of bleeding as well. There are more cases, but I think not statistically significant. But there is slightly increased risk of bleeding if you're using higher dose of enoxaparin. How about aspirin? Since we're talking about immunothrombosis, so in this study by the recovery group, no difference in mortality. However, may have a signal there where there's higher rate of being discharged alive within 28 days. A slight signal for aspirin group, favoring aspirin group, but not enough evidence to suggest routine use. How about tocilizumab? We use it frequently when the patient is having severe ARDS with raised inflammatory markers, raised CRP. Let's say patient has continuous fever, and then PF ratio less than 200. If there's no other exclusion criteria, which, like for example in this study one, which I also use, raised liver enzymes, thrombocytopenia, patient is not immunosuppressed, not neutropenic, there's no ongoing sepsis, then I would consider using tocilizumab for COVID ARDS patients. So tocilizumab has been shown to improve organ support free days, and also survival in COVID ARDS. So 90-day mortality is improved, greater organ support free days for patients who are critically ill. So you have to choose only the most ill patients to give, or at least it has to be at least on high oxygen support. At least 20 mass and above. I guess if nasal prong, room air, probably don't need to give tocilizumab, right? Majority of these patients also receive dexamethasone in combination with tocilizumab. Okay. So this we discussed. So unfortunately, you can't give tocilizumab for patients who are pregnant. So the issue with tocilizumab is it suppresses interleukin-6, and while great for patients who are in hyperinflammatory phase, it can also promote secondary bacterial infections. And we have seen many patients develop severe sepsis after receiving our steroids plus tocilizumab. So you have to ensure strict infection controls in your ICU. If you can afford it, try to keep them, as clean as possible, of course. Of course, it's very hard to do in COVID surges. Our ICUs is so crowded. So many patients inside. Many of our patients succumb to secondary bacterial infections, even as their ARDS starts to improve. Another alternative to tocilizumab is baricitinib. This is oral medication. Again, it's a tablet and can be given for up to 14 days. You can consider shortening it. It works very similarly to tocilizumab, but it's a Janus kinase inhibitor instead of interleukin-6. But it has been shown also to reduce 28-day mortality compared to placebo. So same thing with tocilizumab. Number one is if there's renal failure, you have to adjust the dose. If there's raised liver enzymes, you have to refold it. If patient has immunosuppression, you also have to refold it. Yeah. So similar to tocilizumab. How about remdesivir, antivirals? I have to say I don't use much remdesivir in ICU. If it's on if the ID physician already started it, I continue it, but I don't usually start it, because if you look back at the phase of COVID that the patients come in with, majority of them are already beyond the viral phase. They're already in the hyperinflammatory phase. So giving more antivirals at that stage actually does not, I feel it doesn't really help the patient. But if in this current scenario where patients are, sporadically getting COVID in the community and they come in with, let's say, something else, they come in for MI, they come in for MVA, right? Maybe they're in early COVID. Then maybe there's a role for giving antivirals because they didn't come in for the ARDS, so you want to give some remdesivir to prevent the patient from going into this hyperinflammatory state. The good thing about this vaccination program is even without this remdesivir, the rate of my patients going into ARDS is so low. So so most likely, we don't have to consider this. But this is one of the antivirals that has been shown to be effective if given early. Yeah. So there is a reduction in deterioration if you were to give patients remdesivir. So this study showed that there is a reduction in the patients that require oxygen if you were to give remdesivir compared to placebo. And a short course of remdesivir of 3 days given outpatient also seemed to have reduced COVID-related hospitalizations or death from any cause compared to placebo, just a short course of 3 days. So there's some signal for definitely the use of remdesivir. So I mentioned earlier regarding the use of monoclonal antibodies. So imagine giving a patient some sort of antibodies to block the viral entry into the host cell. So these are called like casirivimab and imdivimab. So if you were to just give it routinely, doesn't show much difference. But if you were to divide the patients to seronegative and seropositive, that means patients who are not yet haven't developed antibodies against COVID. Those are the patients that require this, that seem to do better if they were given monoclonal antibodies, because I think it stops the virus from entering the host cell. If the patient is already seropositive, then adding more of these antibodies doesn't seem to help much. Yeah. So the thing is, you need kits, you need lab tests to find out who are these group of patients. In our setting, unfortunately, we don't have the ability to test for seronegativity or seropositivity of COVID patients. So it has limited role in our setting. How about convalescent plasma? Cochrane study says no benefit for patients with moderate to severe COVID. This is using plasma of recovered patients. So it doesn't seem to help, in moderate to severe COVID. So just summary of what we discussed earlier and from NIH and also WHO guideline. So recommended is steroids, tocilizumab, alternative sarilumab, baricitinib, alternative is tofacitinib, and the newest one is molnupiravir. So these are the recommended. Insufficient evidence, some of this, and not recommended. You should not mix baricitinib and tocilizumab. Colchicine is tested also. IVIGs, the non-specific ones, not recommended, except in children with MIS-C, maybe. Bruton tyrosine kinase inhibitors, other JAK inhibitors like Berry. Only Berry is proven to help. The rest doesn't seem to be that helpful. So convalescent plasma not recommended. How about blood purification? We talk about cytokine storm. There's a raise in the amount of interleukin-6 and so forth. So there are some filters that can, using CVVH machine, there are some filters that can really remove cytokines. And actually we tried it. I think Vincent, one of our MOs, wrote a case report regarding one of our patients that we use Osiris filters to remove cytokines. during his hyperinflammatory phase of COVID. And we planned to use it because patient was septic that time, and we didn't want to increase the amount of steroids we were giving, but patient seems to be going into a hyperinflammatory phase. Of course, there's no strong evidence to support its routine use, but in this patient, when we started the CRT using the Osiris filter, there was a definitely reduction in the CRP, the procalcitonin, the CRP, and also a rise in the PF ratio. But this is just a case report. There were other studies by other people, using other different filters like this Jeffron resin hemoperfusion, cytosorb, another one using Osiris. They seem to show reduction in cytokines, and also in this study, even a reduction in SOFA scores. The evidence is not strong, but we have to wait for more information to decide whether this can be helpful in the future. So empirical antibiotics on admission. Usually patients coming into ICU will receive some empirical antibiotics. I think especially if the patient has diabetes, in Sabah, the setting here, we cover for meliorasis. If low risk of meliorasis, we can go for ceftriaxone or augmentin. If the procalcitonin comes back as low, we can off the empirical antibiotics. But if it comes back as high, then I would wait for the cultures and de-escalate later. HAP and VAP, according to your local antibiogram, you have to decide what you want to give. In terms of cough, a lot of our patients have very severe cough. Some of them cough until, I don't know whether the severe cough is the one that trigger their subclinic emphysema, pneumothorax. So we do give some opioids, DF118, fentanyl, morphine, some other over-the-counter like Prospan, it's an IV leaf extract. Some patients feel they do better, they feel better on it. Benadryl, bromhexine may help. You can try. Yeah. We avoid using nebulizer if we can, but most of our nurses are in PAPRs, our doctors too, and then we have the respirators. So we feel comfortable using nebulizers in our ICU. We used to be unable to auscultate the lungs due to our full PPE, the Tyvek suit. But nowadays, I just wear a cap. I don't cover my ears anymore. So nowadays it's easier to. The most important is to protect your face, the front of your face, right? The ears, I haven't heard of anybody getting COVID through the ear. So I auscultate patients nowadays if I need to. Hydration, most COVID patients are dehydrated when they come in. So I said we use a more liberal fluid resus in the first 1 to 2 days. A lot of them have electrolyte imbalances. Many of them got diarrhea, vomiting. If the patient is not fluid overloaded, there's no need to keep the patient dry. There's no need to less fix the patient, dry the patient up because of hypoxemia. It doesn't seem to help COVID patients. Nutrition, I would let the patient eat as long as they can. Even the patient on high-flow nasal cannula, FiO2 of 100%, 90%, if they can drink a bit, I let them drink. Once the FiO2 comes down a little bit more, he seems to be stable, not tachypnic, I let them eat, even on high FiO2s. They do fine. Yeah, and when you can eat on your own, you can maintain your nutrition. It provides better recovery for the patient. If you have to, you can give enteral feeding nutrition, at least 25 kilocalories per kilo per day. I will give vitamins for the patient. The dosage, I'm not sure what the optimum dose, but this is what we give. You have to correct the electrolytes of the patient. Many of our ICUs report MRO outbreaks during the COVID surge. Number one, due to high load of patients. The other thing is also because a lot of us, that time we wear full PPE, and between patients, we are still in full PPE. So we only remove the first layer of glove. We can't wash our hands properly. Our sleeves are all probably still, carriers of germs, although we change the apron, but somehow the spread of MRO increased, CREs, ESBL. So, you should definitely change your apron and gloves. Nowadays, I just remove the glove, apron, everything, and wash my hands properly before I go on to the next patient. Like I mentioned, the most important to protect your face, N95, face shield, or respirator. If you're wearing PAPR, so go ahead. But I think the body, you can remove your gown, you can remove your gloves, and wash your hands in the COVID ICU, no problem. Yeah. Definitely use disposable utensils. Don't reuse utensils between patients. To wash and reuse, we did away with that. one-to-one nursing where possible. We need frequent environmental cleaning, even in COVID ICUs, and terminal cleaning whenever we get a patient out. So what can we expect going forward? We're going to see more and more patients coming in with other reasons, COVID patients with other problems, trauma, MI, strokes, DKA, either due to COVID itself because of the post-COVID syndromes, or due to the hyperinflammatory state caused by COVID. They come in with the coagulable state, they come in with MI and stroke, or somehow just coincidentally they get a car accident and they're COVID positive. Elective surgeries, procedures, patients coming for dialysis with COVID, and then you have a lot more post-COVID complications, thrombosis, chronic lung disease, this MIS, long COVID. So what can we do to prepare? I think from last year itself, we were preparing to handle both COVID and non-COVID in the same ICU, in the same area. As we go towards the endemic phase, we're going to have some patients coming out positive. So, we need to ensure that minimal risk of cross-infection between the patients. As soon as you suspect the patient is COVID, try to isolate them. If they're PUI, they're COVID positive, definitely have to isolate them. And then you can de-isolate after 10 to 20 days. Whether you need to repeat the RTK, I guess it depends on the guidelines. Some patients after 20 days, our ID physicians say, look, you don't have to repeat the RTK. You can just de-isolate the patient since there's no ARDS, there's no lung dysfunction. But after 10 days to 20 days, I will do an RTK to make sure that they are negative before I de-isolate them. We have to improve our ventilation in the ICU, either by using air purifiers, by using exhaust fans, if you have the budget for it, to develop more isolation rooms, MPR rooms. But I think a lot of our budget goes to a lot more life-saving equipment, and sometimes we just don't have the room, the area to develop more isolation rooms. For our ICU staff, our doctors, or even not ICU staff, even in the ward, I feel universal airborne precautions is the way forward. Wearing N95 when you're near patients, face shield, it's like how we wear gloves for all patients. It's like, oh, this patient got no bloodborne disease, I don't have to wear gloves. You still wear a glove. It's a universal precaution. So same goes for going forward with COVID pandemic. If there's any airborne disease pandemics, I feel that we should be using universal airborne precautions when handling any case, any patient in the hospital. Yeah. All right, so thank you so much. Any questions?
Thank you, Dr. Fong, for a lovely talk. Okay, so we have some question from Dr. Siti. Hi, Fong, you only use an IV in negative pressure room. In our ICU, we don't have too many of this room, and I do agree the risk of aerosolization, as you mentioned. What is your thought on this?
Hi, Siti. Anora, how are you? We use it because our ICUs, the COVID areas are isolated from non-COVID areas. So we have a specific room. We cohort them together in the same room. So in those rooms, we use an IV even without a negative pressure room. Preferably, you would want to put them in a negative pressure room. It's true, but in our setting, we just cohort them together in the same room with all the other COVID patients.
Yeah, how do you manage sedation in this patient? Because they seem to be quite resistant to sedation. And she wondered, what can you do apart from increasing the sedation?
In those patients with severe COVID who are intubated, unfortunately, I don't have a good answer for this. In the initial phase, when the patient is having very high work of breathing, in severe ARDS, the patient needs to be prone, then definitely we have to use high dose sedation. But once they are improving, FiO2 down to 60, PEEP less than 10, we go back to our basic management of weaning, which is, we try to do a sedation holiday, we try to titrate down the sedation, do a spontaneous awakening trial. If they get delirious, then you can use Presidex. You can also use antipsychotics. I tend to use a lot of chlorpromazine or IV haloperidol to treat the delirium.
I have a question for you. Just now you were mentioning something interesting like partial paralysis. I know I should assume it's patient intubated, but
Yes.
Are you doing for like non-intubated with high
No,
respiratory drive?
no.
Okay. So what
Later.
is your this protocol for partial?
I
How
don't
do
have a
you
protocol, unfortunately. What we did was patients were sometimes on full paralysis, and then we titrate down the paralysis. So as we titrate it down, and then you see the patient start to breathe, but they have a nice tidal volume, between 6 to 8 mils per kilo, rather than 1 liter tidal volume. Then you find that that's a sweet spot. If you off it, then patient goes into very high tidal volumes, then you go back on partial paralysis.
what is your thought in using like say TOF machine, TOF count?
I haven't used them in.
Okay. Okay, Nazuha, I have a question. As we're moving towards endemic, has your triaging for ICU admission for COVID patients different now? Actually, this is our talk in the afternoon, but maybe you want to answer a little bit on this?
Yeah, during the search, definitely the triage is different. We have to pick and choose our patients. We had cut-offs to decide which patients we're not bringing into ICU. But as we go towards endemic phase, I think most of the patients come in for the regular, typical typical ICU admissions, the DKA, the MVAs, the strokes.
So it's
ICB.
going to be like a H1 and H1N1 before.
Yeah, exactly. So the triaging goes back to normal. As we get out of a surge, as we get out of a pandemic phase, we should go back to a normal triaging rather than a crisis kind of triaging as we get out of a crisis.
How do you actually implement mobilization in COVID patient?
It's difficult.
Okay, difficult.
In the beginning, when they were all in isolation rooms, it was very difficult. A lot of patients were left a bit, under mobilized. But as we proceeded throughout, last year, 2020, at the end of 2020, 2021, we were more comfortable dealing with them. And then we, by avoiding intubation, they are actually quite mobile in their own bed. They can prone, they can move. Some of them even stand up to do exercise on their own. So they're quite mobile. Some can go toilet.
Perhaps that's the reason you would want to avoid intubation in the first place.
Yes, definitely.
Right?
Definitely.
So they can do their things on their own.
Yep.
If theoretically you can have a point of care machine in the ICU, small machine that can measure all these biomarkers of inflammation, will it be helpful? Because like your talk is like precision medicine towards the certain phase of the COVID. Will it be helpful, do you think, if you have a point of care machine?
I did try to so-called taper steroids according to CRP at some point last year. Unfortunately, I did not see. This is, I didn't do it's not like a trial, but
it's not a full panel of inflammatory markers.
So when the CRP came down, I tried to titrate down the steroids, but it didn't translate into better pulmonary, recovery. And then some of these patients relapsed when we reduced the steroids.
Perhaps if you have an extended panel for inflammatory markers, that would be good.
Like interleukin 6 and so forth, right?
Interleukin 6, yeah. Maybe, I don't know.
I'm not sure. I have to read up more, I think. Whether, a reduction in interleukin 6 actually translates into better mortality. I think I'm not sure about that.
Okay, Dr. Ashraf is asking, do you still use PCR to decide on ICU admission? If yes, all ICU or certain patient?
If the RTK is positive, we don't repeat PCR anymore. We just consider it as COVID positive. Even if the patient is recently COVID positive, I would assume that they are basically immune to getting COVID again within the short period. So I will just cohort them together in the COVID ICU. But if the RTK is negative, and patient is a PUI, or if let's say patient is SARI, patient has lung changes, patient is hypoxic, then I would think twice about putting them in together with all the non-COVID patients because they might still be COVID. So those patients we wait for PCR.
Oh, PCR. Okay. All right. Anyone have any other question? I'm running out of question myself. because
Yeah,
the talk was
but
so
we're
good.
running out of time, I think.
Very good talk. Okay, all right. Thank you, Dr. Fong. I want to pass this back to our MC, Dr. Dash. Dr.
No,
Dash, are you there?
I'm the MC. I'm the MC.
Yeah, I'm still here.
Oh, yeah, yeah,
Okay.
okay. Okay, okay.